Palliative care services. So I'm going to start with George's grandfather, 93 years old, and recently had a hip fracture. Due to complications from his hip fracture, he is experiencing pain, constipation, and confusion. All of these different symptoms can be addressed by palliative care. And for that reason, his medical community has suggested that he get palliative care services for his grandfather. Other people who commonly receive palliative care are people who might have a cancer diagnosis early on in the diagnosis, or even later when it's more advanced. Patients that have heart failure, another common population of people that frequently benefit from palliative care. So why palliative care? First of all, for the symptom controls, people that have had training in palliative care are experts in controlling issues like pain. So hip pain, they know how to use narcotics, even ibuprofen and Tylenol. That's something that palliative care physicians specialize in. They know how to relieve constipation and assist with confusion. So all those concerns the palliative care services can help with. They will also coordinate care. They will answer questions that George and his grandfather have about where they should go to get the care that they need, perhaps physical therapy, should they go to an acute rehab. All of those issues are things that the palliative care team can talk with them about. As I said, it's a medical specialty. It's available as an inpatient and as an outpatient. When people are seen in the outpatient world, they might be seen maybe weekly, they might be seen monthly. But if a person is in the hospital and palliative care is felt to be beneficial, the palliative care service generally sees people every day and can become a key resource for the patient and family. It is paid for by Medicare, Part B, Medicaid, and insurance, just like any other specialty would be. And again, this just reviews all the different areas that palliative care can help with. Communication. I work in inpatient palliative care, and it's not uncommon for me to reach out to a number of different physicians and make sure that we are honoring a person's wishes and that we're giving them the information that they need. It can be very complicated if a patient has heart failure, kidney failure, perhaps has a lung condition. Trying to bring all those pieces together and understand how best to move forward can be very difficult. Education, management of symptoms, which I mentioned. I wanted to stress again that palliative care can help a person at any point of their illness. If someone is recently diagnosed with an advanced cancer, palliative care can be a benefit. In fact, for adenocarcinoma of the lung, it's been found that palliative care can actually prolong someone's life if they've got adenocarcinoma of the lung and it has metastasized. So it can actually, for that situation in particular, it can actually prolong life. So palliative care is not a service that is provided at necessarily at end of life, though it can be provided at end of life. It's generally given to people who are working on becoming healthier and stronger. It's also provided for people who are not going to survive an illness, but for people that aren't necessarily ready for hospice, they're still processing. So that's palliative care. I'm going to move on to hospice now. In my scenario, George's grandfather recovers from his hip fracture, but in time he actually becomes weak, and George notices that his appetite is not what it was. It is suggested to him that he consider hospice for his grandfather. Most people are more familiar with hospice than they are for palliative care. Hospice, like palliative care, paid for by Medicare, Medicaid, private insurance. Hospice is different in that a physician has to certify that a person has a life expectancy of 6 months or less, given the natural progression of disease. That last part is important because it means that we don't know that a person has a life expectancy of 6 months or less. We can say that most people in that situation would live 6 months or less, but there are plenty of people that live longer than what their hospice diagnosed, what have you think. So for instance, I've worked with patients that have been in hospice for a year and a half, even though their life expectancy was thought to be 6 months or less, it actually ended up being much longer than that. When someone requests hospice services, they have made the decision to stop life-prolonging therapy and instead have decided to focus on comfort and quality of life. So they have made a decision that they don't want to do things like do chemotherapy to try and treat a cancer and extend their life. They don't want to have an AICD or a defibrillator to shock their heart if their heart goes into an arrhythmia. Instead, they're focusing on staying home and trying to keep things like shortness of breath, pain, all under the best control possible so they can enjoy their days. The hospice service, unlike palliative care, hospice has a much bigger team. The hospice service has a case manager. They have volunteers who sometimes come and sit with people in their homes, chaplains for spiritual support. They have a 24/7 call system, so you can call them anytime and ask any questions that you have. Hospice also provides medical equipment such as a hospital bed or a bedside commode, a shower chair, and they cover medications as well. A common question that I get is how much bedside care does hospice provide? Hospice does not provide bedside care per se. They might provide an aide who might come twice a week and help with showering or some very basic care in the home, but that would only be for an hour or two. So when someone has hospice care, it's really the caregivers, the family, the loved ones that provide that 24/7 care.
Who decides whether to go inpatient or outpatient?
So
what determines?
with palliative care or with hospice or with both?
Hospice.
Hospice.
Actually.
Yeah, so with palliative care, the palliative care has to be ordered by a doctor, just like any specialty would be ordered in the inpatient world. Outpatient, you can actually ask for it from a palliative care agency, but inpatient, a doctor orders it, and that's how it's decided if it's going to happen inpatient. I'm glad you asked about hospice because I think there's a slide later that comes over this again, but I'm not certain. Hospice can be provided in multiple living situations. The vast majority of hospice is provided in the private home. So a person is living at home or with their loved ones, and hospice comes into the home, and it's usually provided by a nurse. That's the main contact person, and they are seen routinely in the home. Hospice can also be provided in a long-term care bed in a nursing facility. Hospice agencies go into nursing facilities and provide care there as well. The far and away, the most rare situation is for a patient to be cared in a hospice home. You all are probably familiar with the transition hospice home. It used to be Hospice of Wake County. Their facility now has about 30 beds. It is perhaps 1% of the overall, if that, percent of patients that they provide hospice for. So if a patient has a very complicated care plan for hospice, they might go to the hospice home, like the one like Transitions Hospice Home. But the vast majority of people are treated at home because Medicare and insurance will only pay for the hospice home if they meet certain requirements. That's a long answer, but does that answer the question?
Yes, it does.
Yes, absolutely. I also just wanted to mention that it's not uncommon for people to believe that hospice sedates the people that they're taking care of and immediately goes to narcotic trips. That is not the case at all. In fact, hospice's goal is to start early enough in a person's illness that they can avoid giving any kind of sedation or pain medications as long as possible. And I also just wanted to make sure that people are aware that if you have hospice services, it doesn't mean that you can't go to the emergency room or be admitted to the hospital. That's another common hospice myth.
Oh, I'm glad you said that. That was actually, I had that question. I had written that question up too.
Mhm.
And I thought, is it something that I've changed, that hospice, they cannot call 911? Or is that a
Well,
change?
yeah, well, to be honest, the hospice agencies prefer if you call them first, but you can always call 911, always. You would get to the emergency room, they would evaluate you. And if you decide at that point you are still focused on quality of life and being comfortable at the end of life, then the emergency room may need to take care of you and help address some of the symptoms that you're having if you're in a crisis, or you may even need to be admitted to the hospital to receive hospice care if it's complicated enough. But you may also call 911 and go into the emergency room and decide that you've changed your goals of care and you actually don't want hospice anymore. And you can do that too. It's called revoking hospice, and that's completely appropriate. I think that the most important message for me to give is you're always under control and you can always go to the emergency room and tease things apart there, what your next step in care is if you've ever had concerns and you feel like that's where you need to be. Does that answer your question?
Oh yeah, definitely. Thank you.
Thank you. Again, the shared philosophy of hospice and palliative care, though, are to reduce suffering and improve quality of life. But palliative care, the majority of patients that we see are patients that are not actively dying. They're patients that have a complicated illness for palliative care. This just goes again, I believe you all understand palliative care, any stage of an illness or prognosis, and it can be given at the same time rehab is given or any kind of treatment that's focused on a person recovering or getting stronger. And then hospice has the prognosis for the natural course of a life expectancy being 6 months or less. I'm going to talk about advanced care planning for a bit now. I have to say, I'm not a lawyer, I'm a physician. So if you have any legal questions or I give any advice that you're at all want follow up on, a lawyer is really your best reference. So George and his grandfather, they decided to discuss hospice as a next step because his grandfather is now getting weaker. He's having loss of appetite, and they're concerned that he is really moving towards end of life. While George and his grandfather are discussing this, George realizes that this is actually the first time he's ever had any discussions about end of life with his grandfather. And in fact, he has not done any kind of advanced care planning to make sure that his grandfather stays in charge, even if he experiences confusion in this last phase of his life. It's very common for people towards the end of life to experience confusion. Over 3/4 of people at the end of life to experience confusion. If a person wants to stay in charge of their medical decisions throughout their life, they should complete advanced care planning. The most common advanced care planning, at least what gets talked about the most, is generally a healthcare power of attorney or a living will. These are all tools to allow a person to guide healthcare, even if the person is incapacitated.
Can they be revoked? Can family member revoke them?
They can revoke them. That's a great point. If someone does an advanced care, does a healthcare power of attorney, and they want to change their healthcare power of attorney, they get a more recent healthcare power of attorney, an up-to-date one that would replace the older healthcare power of attorney. So you can definitely revoke them.
For the person who wants the, I mean, if someone had decided and then the family comes and revokes, then, I mean, even if it's with an attorney, they still can revoke?
Well, you mean, the person who has a healthcare power of attorney can take it away from someone. Like if George's grandfather says that he would like George to be his healthcare power of attorney, the grandfather can change his mind anytime he wants while he is still lucid. If that's what you mean. If you can identify someone as your healthcare power of attorney, or you can sign a living will and then you can change your mind. That's
How about
reasonable.
someone else? Oh, I meant if someone else, can they revoke another? For example, George's son, can he revoke George's will?
That's a great question. No.
Oh, okay.
No, but I'm glad you mentioned that. That's a really great question. So once you've done a healthcare power of attorney, that's a legal document and it stands and it cannot be taken away by another family member.
Okay, good.
There is, if you don't have a healthcare power of attorney, by North Carolina law, there is an order of who would make decisions for you. And I'll go through that later. But if you have a healthcare power of attorney, that essentially trumps anyone else coming behind and saying that I'm going to make decisions for someone.
Okay.
So examples of decisions that a healthcare power of attorney might make, a healthcare power of attorney could ask to provide guidance if a person would want CPR or not. So if his grandfather's in the hospital and his grandfather gets confused and can't make decisions anymore, then a physician could come to George and say, would your grandfather want CPR? George could be asked for his grandfather, your grandfather's kidneys are failing. Would he agree to dialysis? He's unable to swallow safely. Would your grandfather want us to put a feeding tube in his nose? They're all questions that are pretty routine on a daily basis with that. When I'm working with people in the hospital, all the time I'm asking family members to make decisions for people who are in the hospital and are unable to make decisions for themselves. So it is important to identify a healthcare power of attorney if you have any concerns about who would be guiding your care if you did not have a healthcare power of attorney. And it's extremely important to then tell that healthcare power of attorney what your wishes are. For example, today I took care of a patient and the question of a feeding tube came up, and I was told by the family member of the patient that this patient absolutely would not want a feeding tube, no matter what, even if eating food by mouth was going to lead to aspiration and pneumonia, possibly death. I was told by the family that we were not to place a feeding tube. I had another patient today where the family told me that we absolutely should place a feeding tube to prolong life. They told me that for this second patient, this different family told me that for their loved one, they knew their loved ones, the goal was to live as long as possible. And if that meant a feeding tube, that was completely appropriate. So in both those cases, we were really relying on someone else other than the patient to make decisions.